all the memory of rainy afternoons, swingy Harlem tunes, motor trips and burning lips and burning toast and prunes. How lovely it was. Thanks for the memory of candlelight and wine, castles on the Rhine, and moments on the Hudson River line.
Just the last name of the day.
How lovely it was.
First name of the two.
Okay, our next speaker is B. Hicks, and she's going to be talking about the aging mouth and common oral conditions afflicting the elderly. So please help me welcome B. Hicks.
Okay, I know we're right before lunch. Can y'all hear me? Yes. Okay. All right. So we've heard about the ear, we've heard about the eyes, and now we're going to talk about the mouth. But just hearing about the ears and the eyes, you know, the challenges with the seniors when we're looking in the mouth. I mean, and we're trying to educate them. They can't hear, sometimes they can't see, and so kind of keep those things in mind as I talk about the aging mouth. These are my parents, and they're in their late 70s and aging, and you know, so far doing pretty well, pretty healthy, and you know, starting to have some minor issues, but so we're going to focus on the aging mouth. And you know, we have unique challenges with the mouth. It's kind of one of those things that people don't kind of really think too much about. But there is really a vital connection between the health of the body and the health and having a healthy mouth. So that's the key point I want to really bring across today. I think that the mouth gets overlooked a lot of times, and so I'm here to kind of share with you little things, and hopefully, you know, you'll be able to share that, you'll be able to see that, and maybe possibly do referrals or whatever it is that's necessary. So I'm going to kind of I'm going to skip over this slide because I think a lot of you've seen these slides before and our aging population, but I did want to make a point about this slide because really when you see the red and the green bars right here, you know, really, this is really our population is 75 to 84 years old. That's going to really multiply and increase. And in dentistry, really, that's kind of like, you know, it's a big issues for us because we have certain expectations. And, you know, thinking about and looking at the future expectations of what's happening, really, for the most part, our seniors, the trend is that now seniors are maintaining their natural dentition. It used to be, you know, 20, 30 years ago, you pretty much got older and you expected you'd lose teeth. By the time you were older, you were wearing partials or dentures, and that was kind of the expectation. And that no longer is true anymore. You know, the trend is that people are keeping their teeth longer, and some of them for a lifetime. I had a 105-year-old patient walk into the clinic with a full set of teeth. Wow. Walked into the clinic with her chart, by the way. She wasn't an assisted living facility, but you know, to me, that's just amazing. So tooth loss has actually declined from 50 to 18% in the past 60 years, and 50 to 64-year-olds, now we see loss of teeth percentage, about 10%. That's absolutely amazing to me. You know, and in addition, you know, there have been, you know, seniors are reporting that, you know, they've done studies, a National Health for Interview study, did a study where they actually wanted seniors to report their health. 42% of them reported excellent health, and that included oral health. And so seniors kind of have expectations too, and they kind of think, you know, we want to maintain health, and they're also looking at their oral health now, which is a really good thing for us. You know, in dentistry, what we do is primarily try to look at seniors and classify them according to function rather than look at their chronological age. And that's because seniors are living healthy now, and they're being able to do many different things they couldn't do many years ago. Many and most older adults are in independent categories where they're living on their own and being able to do all the things they want to do. I guess in dentistry, the frail elders are the ones we're mostly concerned with because the research has shown they need assistance with their ADLs, many of them, 41% of the time. Usually they're 65 years or older. And then some of them have actually been reported to have functional limitation. 21% of them report that they can't even do or function with activities of daily living. That's what ADL stands for. And so included with activities of daily living is brushing and flossing and the ability to be able to take care and maintain a healthy mouth. And in this picture you can see this is a healthy mouth. The gums are very firm, you don't see food, you don't see red, bleeding, inflammation, you don't see a lot of plaque, impacted or missing teeth. I mean, this is ideal of what we'd like to see with older individuals. So oral health does matter. And Dr. Satcher in 2000, Surgeon General, kind of put oral health on the map for us. He said, you're not healthy without good oral health. And that kind of put, oral health on the map. People don't realize that dental care is the most uncommon met need, and really we're seeing disparities across all age groups. In our youngest children, all the way through the seniors. And in the younger children, we're seeing a lot of issues with dental decay. And we actually see issues with seniors with dental decay too, and gum disease. So oral disease can severely affect overall health. And the good news is that really oral disease is preventable. And there are things that we can do now that connection has been made between systemic health and oral health to be able to keep that mouth healthy. And it is preventable. Many of the elderly are at risk, and primarily the issues we're concerned with in dentistry is chronically ill, systemic diseases, low income, 14% of those over 65 live in poverty. Minority elders tend to have lower incomes, and many of them lack dental insurance. Medicare does not pay for dental treatment or coverage. So a lot of seniors have to either have their own private dental insurance or go to, nonprofit organizations that will give them discounted care, dental care. Really our homebound institutionalized elders, or those who live in nursing facilities, those are the ones that are greatest concern. And I already shared about how, they may not be able to brush, or if they can't brush their hair and they can't dress, the odds are more than likely they're not going to be able to care and brush their teeth, okay? Much less floss. Okay? And then are disabled and rural. Those seniors that are living in disabled and rural areas are our greatest challenges. When we look at our growing healthcare needs of seniors, it's complicated dental needs based on all these different things. They are retaining their teeth longer, which is really good news, okay? Yet we're still seeing high levels of disease. 50% of elders perceive their dental health as very poor or poor, and that's in a study that was done. And most elders really receive commonly 32% cavities and about 23% gum disease. So we do have to consider and think about age-related changes. One of the things that happens with age, well, again, tissue becomes very frail, the lips and the cheeks, and so one has to be very careful in going in the mouth, not stretching the cheeks really too much or doing anything that could manipulate and tear the tissue. It's a little more frail the older a patient gets. We also see what the word receding gums. Some people have probably heard that word. And wear on the teeth. Okay? This slide kind of shows the long teeth. It shows the teeth, are flatter, a little flatter. And so that's all the result of, it could be bite, it could be what they're eating, diet, many different related factors. Normally, recession or receded gums is not normal. It's not considered a normal part of aging, but it is related to disease in some way. It could be that a patient has periodontal disease, a patient has other factors related in the oral environment, even physical factors, such as brushing their teeth really hard with hard toothbrushes. There's still a lot of elderly patients that use hard toothbrushes. And one of the things you will see that happens is that you literally will expose, this is the enamel of the tooth, the hardest surface of the tooth, but you'll expose the root surface of the tooth, which is really much softer. which can present other problems, which I'll show you in a minute. But so hard toothbrushes and brushing with hard toothbrush can cause receding gums. And so, we always recommend a soft, and sometimes the seniors that are frail, extra soft toothbrushes work really well in making sure that you're not causing trauma in the mouth. So what are the challenges presented with these receding gums and the exposure of the root surfaces? The root surfaces actually have cementum, which is really covered with cementum. It's very soft compared to the enamel of the tooth surface, which really means that our older seniors are really susceptible to root decay. And so here you can see the exposure. You can see root decay beginning right here, and kind of right here, here. So again, the longer the teeth appear, it could be that they're going to be highly susceptible to root decay. It's very soft. And so again, these can be treated with amalgams for the back teeth, mercury or silver fillings, and the back teeth, so that's why it's not going to be very aesthetically pleasing if you put that on front teeth, and glass ionomer cements for the front teeth. We don't generally recommend extractions in dentistry, not even with seniors. You might say, oh, there's decay, and just extract the tooth, take it out. I'm older now. What people don't realize is that missing teeth can cause food impaction, plaque impaction, present a challenge trying to clean the areas of the teeth, also presents a challenge with eating and chewing, things you may not think about, speaking. You have missing teeth in the back, patients may bite their cheeks a lot because they're missing teeth. So again, if you have to have teeth extracted, the recommendation is a partial, or eventually, hopefully, you won't have to get to where you have to wear denture. So this is another example of extreme case of root caries in this patient, and all this can be treatable, and it can be restored. So other age-related changes, if the teeth do become yellower as you get older, what we see is that organic matrix declines. We see more reparative dentin being laid down, which is a layer underneath the enamel. So the teeth tend to be a little more yellow, and it can present a problem with seniors that want to bleach their teeth. In 2006, the survey was done, and really bleaching outcomes may be negatively influenced by this factor alone. The seniors may not be able to see an improvement in the whitening of the teeth. And also we just suggest that professional applications is better than getting the over-the-counter ones, because those can be misused and many other issues related to that. The other thing we see with seniors is reduction in tooth sensitivity. We have, in essence, with the pulp, sensitivity and nerve supply is reduced. And so as a result of that, a senior may have a lot of decay and not complain about that their teeth hurt, that they're having pain. And so it's not uncommon for a senior to have decay and they're not complaining and they don't have any pain. So that's not uncommon. I wanted to briefly talk about gum disease because it is a chronic disease. It's a bacterial infection that leads to tooth loss. Okay? This is a chronic infection, and it's not an infection that can go away easily. Okay? It needs to be treated, and primarily you want to think about this disease not just local anymore. There's a lot of research being done, systemic disease and oral health, and how they've actually been able to isolate and find oral bacteria in there are arteriosclerotic plaques, or hard time saying that big word, and so the inflammation process is a big issue. Chronic inflammation, there's a lot of research being done with that. Some of the things they're finding is that the bacterium plaque, they found that seniors are in long-term care facilities are at high risk for aspiration pneumonia. And they're finding with the research they're doing that if they have adequate home care, that they're going to be able to actually reduce the risk of aspiration pneumonia, because they're finding that when they isolate the lungs, they're finding that bacteria in the lungs, oral bacteria in the lungs. Some research also with diabetic patients that have periodontal disease cannot maintain good, adequate glucose control. And so those are the big issues in some of the research being done. But when you look at this bacterial infection, what happens is the bacteria, this is like a normal tooth gum level, and if you see the other slide, these two extremes here, you can see that the teeth look long, the gum level's lower. Okay, so what happens is the bacterial infection creates a biofilm which invades the supporting structure of the tooth. And when that happens, literally a patient can lose the destruction of the bone that supports the tooth. And when that happens, we'll see mobility, we'll see exudate. In long-term care facilities, patients can swallow their teeth that are mobile and loose. And that's severe periodontal disease. And so hopefully, this can be prevented, by going to a dentist regularly for exams, getting, if a patient has periodontitis, keeping them maintained, by going every 2 to 3 months with, and getting a cleaning, a periodontal cleaning. And so it can actually be maintained and or prevented. And some other big etiologic factors of periodontal disease is systemic disease, diabetes, for example, smoking and tobacco puts a patient in high risk, of course, lack of dental care, and then, of course, not even having any home care will put a patient at risk for periodontal disease. This kind of shows you a picture of a patient that actually, this is hardened plaque called calculus or tartar. We always hear about these tartar toothpastes, tartar controlling toothpaste. And so once it gets hard, you have to actually have a professional cleaning. But underneath all of that is biofilm and bacterial infection that can invade below that space and destroy the bone pretty much. You can see infection, you can see swelling, inflammation in this slide. So some of the other issues with seniors is xerostonia, dry mouth. Okay? Dry mouth, not necessarily, something kind of what we want to think about is something that is not really as a result of age, although we do see a decrease in salivary glands, but it's not necessarily because of age people get dry mouth. The primary causes is really systemic diseases, diabetes, Sjogren's syndrome is the destruction of the salivary gland disorder, Parkinson's, patients that have cancer, head and neck radiation. Secondary causes could be stress, anxiety, nasal congestion, breathing, mouth breathing. Medications is a secondary cause and really is one of huge issue with patients that have dry mouth due to medications. So all our cardiovascular medications, our depression medication, our antihistamines, our anxiety medications, so many of the medications actually cause dry mouth. And so it's a huge issue in dentistry. Your patient might be complaining to you and say that their tongue is burning or that they've noticed their tongue is sticking on the top of the roof of their mouth. That's severe dry mouth, but that does happen. When they open and you're doing an exam and you're looking in their throat, look at the tongue. Is it inflamed? Is it red? Is it swollen? Those are all signs of dry mouth. They may complain that they can't taste, have difficulty swallowing, and you notice increased root caries. Saliva acts as a buffering agent for our teeth. It actually protects the teeth and helps with a remineralization process that the decay doesn't begin. So when we lose saliva, we have dry mouth, a perfect environment for increased caries. And if you have root exposure, root caries. With the dry lips, we might see angular callosis, cracking and drying of the corners of the mouth. And with that can come also candida infections and occur in the corners of the mouth. And so if that's a chronic infection that doesn't go away, it may be necessary to prescribe some sort of antifungal topical agent. And then, overall complaining of bad breath, that something's maybe going on. So what can we do about dry mouth? Suggestions: drink water, sip ice, buy over-the-counter salivary substitutes. I try to kind of list a few of the more common, popular ones. Sprays, there's sprays, toothpaste, gels, gums, and the research kind of has shown that, every patient's different. Patient can try it, maybe substitute, if that doesn't work, then instead they like the sprays and that works for them better. So they all work really well. I know my mom, is on cardiovascular medication, so she really likes the gel. And she puts it on her tongue, she puts it on the cheeks, and that kind of really helps in stimulating saliva fur and helps her. So, you know, a lot of different products out there that are available. There's one that we just got in our clinic, and it's called, by a company called Oracoat. And I really have liked the product because the product itself is really, Xylomelts is what they're called. You can find them at CVS, but provides hours of comfort. You take this little tablet and you put it on your gums and you stick it there, and then it will stick to the gum tissue, and it slowly releases and stimulates saliva in your mouth, so for a 2 to 3 hour time period, which is really nice. So that Xylomelt, I didn't put that on there, but it's by a company, Oracoat, and available at CVS. And so a lot of different products. Xylitol is another one, real popular product. And Xylitol has been known to reduce strep mutans that causes dental decay, and also stimulates saliva. And so anything that has xylitol as a first ingredient, it could be gum, it could be mint. Now please keep in mind that if you recommend a gum, it has to be sugar-free, or, you know, and we recommend xylitol as the first ingredient. And so mints, gums is what you can recommend. I actually did put Xylomelt there for the patient to, you know, chew or suck on during the day, which is very helpful. Avoiding caffeinated products and alcohol can be very drying. You have to be careful with the mouth rinses that contain alcohol. So Listerine has a new product called Listerine Zero. Zero meaning it doesn't contain alcohol. And so you want to go with something like that because alcohol is very drying. So alcohol is actually probably the worst thing that you can do. And then visiting the dentist frequently so that you're not getting decay. And then topical treatments, fluoride treatments, toothpaste and rinses that have fluoride in them. We advocate fluoride varnish. Patients in a high-risk category, they can go to the dentist every 3 months and get fluoride varnish applications on the teeth. And it's just kind of like something we brush on the teeth. It sticks to the teeth, and it is really found to reduce root caries incidence. So with our target population, you know, there's a lot of medical needs. Homebound we're concerned with, our hospice patients, the elderly patient and physical restraints. Those are the patients that are in bed most of the time, and the elderly finally too with financial restrictions. So when we try to approach dentistry, it really has to be from a multidimensional assessment. We want to look at the medical and the dental history, the frequency, the type of systemic disease they have, the type of medications they're on. We'll look at the dental history. Have they had treatment and prior treatment? Have they had periodontal surgeries? What kind of treatment have they had? Or have they never been? We want to look at functional history. Functional history is a huge priority for us in dentistry because, you know, if a patient cannot adequately maintain their oral health, then we're going to have to actually employ the assistance of a caregiver or someone to help the patient. Cognitive issues are also listed under functional health. If a patient has Alzheimer's disease, you know, they may or may not remember to brush their teeth. That's pretty much how simple it is with dementia, some of the cognitive issues. Nutrition and diet also, we have to look at that, their intake of sugars and diets, etc. And then self-care, you know, evaluating that on a regular basis. So we're going to talk a little bit about some of those things. So, you know, does the patient wear dentures or partials? Those are really big issues for us to be thinking about and be concerned about. Is the patient, you know, able to maintain their teeth, their normal teeth they have, and or do they have partials and dentures, and also are they actually able to care for those partials and dentures? Lifestyle, diet, adequate amount of number of teeth, and then functional status, okay? So in geriatric dentistry, really the goal is to be priority driven. We really feel that dental care is medically necessary, okay? So for our residents that are in long-term care facilities, really the emphasis is on oral hygiene care plans, trying to focus on a specific care plan for that individual that perhaps needs the assistant of a nurse assistant or nurse, perhaps they need medications. What are the kind of issues that they may need in long-term care facilities? And so that's what we call oral hygiene care plans. We want to eliminate oral pain and discomfort. Again, I mentioned earlier, seniors may not be complaining about pain in the mouth. But if they are complaining, then we do want to find out where the source of discomfort is. Biggest challenges with patients with dementia, they may not be able to express that. And so symptomally, they may not be able to say, oh, it hurts here, or they may not know. We want to maximize the dentition for nutritional intake. Remember that your teeth are really important for chewing. And they're also very important for speaking. And so, you know, if your patient's having those challenges and you've noticed weight loss, you've noticed that maybe they are not being able to speak very well, then you want to consider could be some problems with the teeth, okay? And really important and critical is to employ the family and the caregiver. As a patient, functional limitations go down and they decline. Research pretty much shows that, you know, they're going to really have a lot of issues maintaining their function in their mouth. And so that's the time when it's going to be critical to really get caregivers to come in and help. And one of the biggest challenges we have with, we've got a lot of seniors living independently at home, some get nursing care, some live in long-term care facilities, but dentists, really there's not a lot of dental practices that go into long-term care facilities. And so dentists are unwilling, or that perhaps they don't have, there was a research done in 2010 where they maybe don't have the necessary equipment that they need to go into long-term care facilities. And then of course there's big issues with long-term care and reimbursement issues, patients not having dental insurance, et cetera. So again, those are our biggest challenges, I believe. And really, you know, as the patients get older and we start seeing in the future all these complex needs, dentists are going to really have to be trained in you know, using equipment, portable equipment, finding ways to be able to treat patients in long-term care facilities. Because if it doesn't happen and ends up becoming a downward spiral, that really leads to poor oral hygiene, oral infections, increased risk for aspiration pneumonia, feeding difficulties, etc. I wanted to talk a little bit about functional status because I am a dental hygienist, and that's really my really primary focus is prevention. And so really when we look at functional status for a patient, you know, we really want to evaluate the patients, whether or not they can even hold a toothbrush, okay? I mean, simple things you may not even think about are huge with our seniors. And so Dr. Saunders actually invented or came up with this is called the grip strength test. Okay, and so what we'll do is we'll evaluate seniors and we'll say to them, we'll put one finger out and we'll say, well, can you hold this finger with your dominant hand and is a firm grip, okay? If it's weak and they're struggling to grip it, then you move it to 2 fingers, and then you can go as far as 3 fingers. And so what that does is it tells us that a patient, if they don't have a good firm grip with 1 finger, they will not be able to hold a toothbrush, a normal toothbrush. It's about the width size of a toothbrush. And so what we want to do is we want to find ways either that we can adapt the toothbrush, or we could suggest electric toothbrushes are usually very wider handles, okay? But we do have to kind of think about that and see if our patients can use that and adapt with that. There's a lot of adaptations that can be used. We like to use insulated foam. You can buy it cheap at Home Depot. And they come with even sticky Velcro, and you put it around your toothbrush, and then they can hold it that way. Tennis balls, bike handles, there's a lot of occupational therapy websites with grasp and handles that have grips on them. So things that you may not think about or consider, you can do the adaptations yourself, or you can, you know, recommend or suggest something to patients and or caregivers. I do want to mention, because we do a lot of training with nurses, the use of the swab. Okay, I think a lot of people think that using a swab will brush a patient's teeth and it will not. Okay, a swab, all a swab does is remove food debris. You can use it to moisten the mouth if you have gel or some type of gel you want to apply to the mouth, but it is not a substitute for a patient getting their teeth brushed. And so it's important to understand the use of swabs. And I know we use them a lot in the hospitals and various uses, but really a toothbrush is the only thing that's going to go in there and remove the bacteria and the biofilm in the plaque. Other aids, and I wanted to bring these up because we do have challenges in long-term care facilities. There's a toothbrush called the Cullis Curve toothbrush and the Dr. Barman's Dewar Power Sonic brush, where you go in there and it actually literally will cover the chewing surface, the outside surface and the inside surface in one sweep, you know, and you'll be able to brush. And those for your bedbound patients, the patients that are not cooperative, like the ones with dementia and Alzheimer's. We use open wide, has a mouth prop. We can use for residents that are non-cooperating, don't want to keep their mouth open. And then finally up at the top here is a product called Xylitol. It's a xylitol oral cleansing solution that's safe to swallow. So, you know, a lot of our dementia patients, they can't spit or they may not understand the instructions, or maybe they can't hear the instructions, you know. They can swallow this safely and it's not harmful to their stomach. If you use regular toothpaste and they swallow it, you know, that could be distressing to the GI system. And so it's called Xylitol, and it's an oral solution. You can find it at xylitol.com. And guess what? It's laced with xylitol, has xylitol in it, so it's a protective mechanism for dental decay. Some dental partial considerations in patients that are wearing them. I think there's a big myth that once you get dentures, you don't never have to go to the dentist because you pretty much got your teeth and you never have to go. But you do. You have to get your exams. It's recommended once every 6 months. You get a regular exam. And that's to assess the appliance itself and also to look for oral lesions in the mouth. Patients that keep their dentures or their partials in and don't clean them adequately can actually end up with oral candida infection, ulcerations in the mouth. It's important that they visit the dentist to get this regularly assessed. Take the denture out each night. It's recommended every night, the denture or the partial, to aerate the tissues, because if it doesn't happen that way, then the fungal infections, that's where the fungal infections can occur. And then if you think about your patients that are medically compromised, that puts them in a greater risk. Denture adhesives, it's important, you know, if you have a patient that tells you that, and they're using a big glob of denture adhesive, and that's the only thing holding in the denture, it's time to visit the dentist. They're really only for assurance, and you should only use very minimal, maybe 1 to 2, 3 drops on the denture itself. But if it's the only thing that's holding the denture in, then that means that denture needs to be relined or perhaps redone. We clean the denture, brushing it at night with a denture paste. Dishwashing liquid, a mild detergent is fine, 1 or 2 drops. Never use toothpaste or anything that's abrasive because it can scratch the denture. Bleach can whiten the denture, so keep those things in mind. And then soaking them at night in water with denture tablets that are made for dentures. And, you know, go with the recommendation of your dentist in terms of what type of tablets, what type of denture toothpaste to use, because there are all different types of appliances made with different types of materials. And finally, you know, nutrition. You do have to consider tooth loss. In dentures, if a patient has dry mouth, they may not even be able to wear the denture because it can be very painful. So think about how that can alter the diet. The other thing, you know, that happens is changes in taste buds in our mouth as we get older. So changes in taste buds, changes in the smell. And so a patient, you know, may not be able to chew efficiently if they don't have teeth, the chewing efficiency. If they have extreme dry mouth, tongue will interfere with that also. So again, they're not going to be able to get adequate, important nutrients. So we try to really also include in our recommendations nutrition, eating nutrient-rich foods, trying to reduce the sugar consumption. Seniors tend to snack on sweets and treats a lot, and so all that does is contribute to dental decay. And so we really try to say sugar-free, or limit your snacking the way you do that. Go with reducing the sugar consumption, especially if a patient is in a high-risk category for dental decay. So we caution them about snacking, and we ask them about their diet. What are they eating? What kind of foods do they snack on? Another thing I wanted to mention is sport drinks. Huge with seniors, but our seniors are very active these days. They're exercising. We have all these wonderful WellMed, wonderful training clinics, and they're really getting out there and exercising. And all the sports and energy drinks, by the way, are highly acidic. And so that can actually contribute to enamel erosion, which kind of literally erodes the enamel surface of the tooth, which can lead to tooth sensitivity and also susceptibility to dental decay. And so, my daughter just did a research in her 8th grade class on sports drinks and athletes, and we actually tested the teeth and how highly acidic the energy drinks are. And I mean, they were very acidic, and really it's amazing to me that our seniors are doing the same thing. They're drinking all these sports drinks, Gatorade, Powerades. The ones that tested the highest for us were Powerade and Red Bull, the Red Bull energy drink. And that's, but everybody's doing it. But there are really consequences to these high acidity sports drinks and energy drinks. Of course, as a hygienist, I can't emphasize enough our prevention steps, brushing and flossing regularly. The biggest challenge for our seniors is flossing. I mean, flossing takes a lot of dexterity. And so if our seniors have arthritis, we really have a lot of seniors with arthritis that can't even really grip the floss. Think about how small that little string is. We were talking about early visually looking and threading a needle, things like that. Well, they're not going to be able to adapt the floss. So there are a lot of floss aids, floss handles. I like the use of floss picks. And, children use those a lot because they don't have dexterity until they get a little older and they learn to manipulate the floss. But there are a lot of things that can be done. There are floss aids like water flossers, air flossers. I brought an air flosser today, and I'll pass this around. The thing about the water flossers, and I'm not a real big advocate with older seniors, particularly frail seniors, with water flossers, just because if they're having problems with difficulty swallowing, sometimes the flow of the water can seem a lot for them. And, I bought my mom as a gift for, it was my mom, I'm sorry, it was my dad. For Christmas, I bought him a water flosser because he always complains he doesn't like to floss. And so I bought him this water flosser, and he doesn't have any medical issues at all, but he really had a challenge with the water flow. And to him, it was just like extreme. And so I returned that and went to the air flosser. And this is what the air flosser looks like. And a lot of water flossers are great for our independent seniors that have good function, that can, they're great, and they actually have been proved to be just as effective as flossing. And so, not that I wouldn't recommend it, but you need to be careful with those who are frail. Elders, I wouldn't recommend it for them. And some of the water flossers that handles like this is an air flosser. This is made by Philips Sonicare. And what it does is you put the water in this little system here, and then you push the button, it dispenses and pulses the water in the areas where you place it. Biggest challenge with this, you have to keep filling out the water reservoir. This is an older version of it, and I'll pass it out, I'll pass this around. But for the seniors that have dexterity arthritis, they can't use that. It's great. It's got a thick handle, and maybe even a caregiver can use that to manipulate that, so long as the patient does not have any problems with dysphagia, swallowing, etc. So those are the key things. Chloride products, over-the-counters, we advocate that especially because of the high risk for root decay. Alcohol and tobacco, I talked about the risk there. Visit the dentist twice a year. It's really important, that our seniors get regular care every 6 months, depending if they have perineal disease, it may be more frequent. What we find with our seniors is that our seniors tend to, sometimes the more frail they get, they may need to be coming to the dentist on a more regular basis, 2 months, every 3 months, depending on what the needs really are with the patient. And also depending on the caregiver and how well the care is being given. Now I wrote that number down, but we have just built a new dental school building, and that number has now changed. So we do have a geriatric dental clinic that really meets the needs of all seniors, whether they'll be independent or they're frail or living in long-term care facilities, and that is run by Dr. Van. And so I'm going to give you the new number. It's 450-3290. 450-3290. And so, we really try to work, our dental hygiene students work in that clinic also in prevention and working with the seniors and or the caregivers or the nurses, whoever comes to bring the patient. And so we're moving to our new clinic, and it's a wonderful, really opportunity. Dr. Van is highly trained in geriatrics and really knows the seniors and the great needs that they have. And so really, really happy to know that we have that at the dental school.
I have a question.
Mhm.
Are those adaptive devices or those things for the patients to use, are they affordable?
You can make your own. It just depends. I mean, like I told you, you can get those insulin foam insulators at Home Depot. You can get along to for $2 or $3. And so they are very affordable. The ones that, even the ones that I've seen on the OT websites, you have to go on and look, I don't think are unreasonable. You know what I'm saying? Because they're devices you'll use all the time. Some of them are just permanent.
I was just thinking more in terms of like a water flosser, for those that have dexterity problems. Would those be?
They're pricey. I'm not going to say that the water flosser's inexpensive, but for the long term and what it's used for and the benefits of it, and you're just buying it for that one-time use, I think it's worth it. I think some of the water flossers you can get at Walmart, $65. The air flossers can be as expensive as $90, $95. So keep in mind, for someone that doesn't have the money, that may not be something that's doable. Instead, then you could go to a water pit or a floss handles, that kind of thing. Okay, in summary, well, it is a multiple dimensional thing when we look at dental and all the oral health care needs with our seniors. We really want to understand that our goal is the same as your goals, to really meet the quality of life for the patients, and that the quality of life and that the outcomes will be towards health, and the vital connection of oral health to the body, and how important it is that if you have infection in your mouth, that means and doesn't mean that the body's healthy. Consider the treatment options. There are a variety of treatment options. We try to be as conservative as possible. Try to do what we can depending on the level of the patient and where the patient is. And you can never, ever exclude the family and the caregivers. The older the patient gets, the more frail, the more functional limitations that the patient may have. And that really, in the end, those are what I find in many years of working in long-term care facilities. We've set up portable dental equipment in long-term care facilities. For many years I've done that. Really, to me, the key thing is the family and the caregiver. Okay? And training them and working with them and educating them and getting them involved along with the senior. We never really, we always include the senior in the education piece, speak to them, give them the amount of respect and individual respect that they deserve. And so it's a team. It's a team approach. And when we go and move into long-term care facilities, it is also very much an interdisciplinary team, working with the doctors, working with the nurses, working with the nurse assistants, the caregivers, and the family members. I mean, it's all interdisciplinary, the speech therapists, the OTs, the PTs. I mean, I've seen it work wonderfully and beautifully when all the team members come together in trying to meet the goal of overall health for the patient. So I want to thank you for your attention, see if anybody has any questions.
Of course. You talked about the air flossers versus the water flossers, but what I would like to know is for people with sensitive teeth, because I've heard people say that with the water pick, it hurts unless they put warm water. Now, I can see with maybe a portable water flosser, you could always have warm water if you have to fill it every time. But what about the air flosser? Does that kind of affect the sensitivity?
You know, the hard part about that is it varies from patient to patient.
Okay.
It's interesting if a patient has a lot of root recession, they may not be sensitive versus another patient that will. So there's a lot of factors, multiple factors that lead to that. And so, you know, not a lot of research been done on that, but the recommendation, certainly you could put warm water in the air flosser.
Yeah.
You can.
Oh,
And that would help, you know. Yeah, there's just water, distilled water in that chamber. And I don't know if water flosser or a water pick recommends warm water in the water flossers, because it's always cold water that I've seen the directions. So it probably may not be for that person, if the person has too sensitive.
Are the small handheld ones, or like the air flosser that you were just talking about, is that a little less hard than water pick is?
Well, it is because you can control the pulses and the release of when the water comes out and spurts out. And the water spurts out pulses and it'll stop. And you have to hit the button each time to get the pulses to come out. So it's a little more controlled. That's what I like about it with the seniors that are more frail.
Okay, thank you.
What was the disease or
Can you speak up a little bit?
The disease or the condition that you mentioned about the corners of the mouth, like the mouth is dry and then this, what is that again?
What or what?
There was like a disease or condition that you mentioned in the corners of the mouth?
That's called the corners of the cracking of the corners of the mouth. It's called angular callosis. That's what we call it in industry. And it could also be as a result of dry mouth. It could be other systemic conditions, patients that are on long-term antibiotics or corticosteroids, getting nutritional deficiencies can get angular callosis. So you kind of have to rule out all those different things, but dry mouth can also create the cracking in the corners of the mouth.
But you called it something like
Oh, it's a candida infection, correct.
What is that?
Candida infection, which is really a fungal infection.
Oh.
Candida albicans is the primary
Yeast?
fungus, the yeast infection. That's correct. Any other questions? Okay,
Last question, is that UT senior dental, do they have to have an insurance or it's a free service?
The Health Science Center Dental School accepts private insurance. They work with patients. It's not a free dental service, absolutely not. But they'll accept private insurance, they'll accept payments, they'll work with you on plans. They also have dental students that work with seniors and our dental hygiene students, and when that happens, there's a discounted fee for that. So seniors get discounted fees when they're being treated by dental students and dental hygiene students. So, but no, it is not a free service, but you know, it's not grant funded or anything like that.
For people who belong to AARP, I just found this out and I've belonged to AARP for a long time, but for people who belong to AARP, there is help. I mean, it's not really insurance, but it's part of your membership. You get discount dental care.
And certain dental practices would have to participate in that.
Yes.
Absolutely. All right, well, thank you so much for your attention.
All right. Okay, who's hungry? Who's ready to eat? No one? Okay, our next speaker is going to be, lunch will start now and we'll resume at 1 o'clock sharp. So we'll see you then. And that'll be our next speaker with the Leanne Oaks talking about models of
motor
palliative care
trips,
in
burning
clothes.
lips,
Come
burning
on back,
toast.
thank you.
How lovely it was. Thanks for the memory of candlelight and wine, castles on the Rhine, the Parthenon.
And moments on the Hudson River line.